Now, with this table, we're going to quickly run through this pharmaceutical agents that are then appropriate to treat different parts of or different types of blood pressure. Thiazides, we talked about this already. First line usage. Patients with gout, pregnancy, electrolyte disorders, avoidance. Be careful, please. Because with thiazides, it's the fact that every once in a while it's able to actually retain certain things, right? And thiazide, tell me about its effect on calcium. It doesn't get rid of it, it actually holds on to it. Where does it work? I told you earlier, it works on the DCT, works on the receptor that PTH works upon. And there's every possibility that thiazide might actually reabsorb the calcium. Keep that in mind. Beta blockers, prior MI, stable angina, atrial arrhythmia. What are you trying to do in those patients? Well, hypertension. But then if it's stable angina, remember, what are you trying to do with this patient? It's the fact that you're trying to decrease the demand of oxygen by the heart. And so therefore, by giving beta blocker and stable angina, who's your patient? Hey, doc, walk a couple blocks and, I have chest pain. I stop and the pain then goes away. Right? Exertional angina, stable. What might you want to do? Beta blocker. Hypertensive, these are issues. But avoidance. If your patient already has heart block, if it's some type of, let's say, AV nodal type of blocks, now why would you want to use a beta blocker? There's every possibility that you might stop the heart permanently. Why would you want to do that? Sick sinus syndrome, same concept here as well. It's the fact that you have an arrhythmia in which there's going to be a little bit of a gap, right, as far as your EKG is concerned, and you don't want to stop the heart permanently. COPD, remember please, if you stimulate your beta-2 receptors, albuterol, inhalers, what are they going to do? Whoop, bronchodilate. So please make sure that you pay attention to great detail as to when you use a beta blocker to make sure your patient is not suffering from bronchospasms, because then you may exacerbate it. Same thing with asthma. Let's continue. ACE inhibitor. You tell me automatically your patient, if has diabetes, if your patient has diabetes mellitus, ACE inhibitors would be a good thing. ACE inhibitors would be contraindicated. Which patient, please? We talked about this a number of times. Atherosclerosis. Remember, the patient in the body requires angiotensin II to then preferentially work on which arteriole? Efferent. You constrict it, you're going to restore GFR. And so therefore, by giving an ACE inhibitor, all you're going to do is exacerbate it. So make sure that you pay attention. Pregnancy, renal vascular hypertension, and angioedema are conditions in which you try to avoid ACE inhibitors at all costs. Definitely pregnancy, because it's a teratogen. Not only is it going to work on the pregnant lady, but it's going to kill that fetus. You kill the kidneys, kill the fetal kidneys, and you don't want that. ARBs, heart failure, diabetes, kidney disease, pretty much the same issue here as well. Calcium channel blockers, atrial arrhythmia, and especially Raynaud syndrome. Who's your patient Raynaud? They walk out into the cold. When they walk out in the cold, what may then happen to the fingers? You may then have aggregation, right? You might actually have cryoglobulinemia. And when you do so, then what then happens to the digits? The digits then may become bluish and cyanotic. Welcome to Raynaud's. And so therefore, you're thinking about using calcium channel blocker. However, avoidance, once again, heart block, sick sinus, pregnancy, and heart failure. Aldosterone receptor blockers, and here once again, prior MI, heart failure, pregnancy, and hyperkalemia, definitely avoid by giving, remember, don't forget this, aldosterone normally exists to get rid of your potassium. If your patient already has hyperkalemia, maybe secondary to renal failure, and you give an aldosterone blocker, the effects of aldosterone have been lost. What are you going to do? You're going to exacerbate the hyperkalemia. And what is that going to affect? It's going to affect your heart, right? Isn't that the number one organ you're worried about? Absolutely. And so therefore you might have T-tenting, as you should know.